we'll take some samples. There are some landmark trials, landmark studies that were done in relation to ILD and other manifestations that we are going to discuss. And the last part will be screening and treatment. As we all know, rheumatoid arthritis is a chronic inflammatory disease, usually diagnosed with just a criteria. Pre-2010, this is the criteria of some 6 symptoms and signs, and lab investigations are there. And if a patient fulfills 4 of them, then you diagnose rheumatoid arthritis. So rheumatoid arthritis, in the first place, is a clinical diagnosis. You don't need serum rheumatoid factor or CCP level to diagnose rheumatoid arthritis. But post-2010, there was a new criteria by the American College of Rheumatology and their European counterpart. They said any patient who has synovitis of at least one joint with no explanation needs to be tested for a possibility of rheumatoid arthritis. And it's a point system, 6 out of 10. It's more or less similar, but it's a little bit different. And the points are given based on the number of joints involved, serology markers, acute phase reactants like CRP-SR, and duration of symptoms. So this is basically the criteria, and you fill these numbers and you diagnose rheumatoid arthritis depending on this criteria. Rheumatoid arthritis, normally it is females are affected most of the time. Age could be any age, but 25 to 50 is the commonest age. There is familial and twin clustering that is seen in different genes. And nearly half of the patients, 40 to 50% of patients, have articular manifestations. In relation to the lung, there are different disease entities that can happen because of rheumatoid arthritis. Most common one being pleural effusion, but ILDs like UIP pattern and SIP pattern, LIP pattern can happen. Other patterns are also there. Organic pneumonia, airway abnormalities can also occur. Emphysemas, bronchiectasis, and drug-induced abnormalities also could happen in patients who have rheumatoid arthritis. So from those patients who have extra-articular manifestation of rheumatoid arthritis, about 22% of patients might have respiratory abnormalities. So it is not a low number. So it's 20% of all the extra-articular manifestation is commonly pulmonary abnormality. The first disease that we are going to discuss is going to be RAILD. Usually rheumatoid arthritis is female predominant, but rheumatoid arthritis-associated interstitial lung disease is most of the time it's male predominant. And you see most of the time high titers of rheumatoid factor and rheumatoid nodules are seen in these patients. And if patients smoke and develop some type of emphysema, usually they have upper lobe emphysema and lower lobe fibrosis. Because of this, there is a phenotype of abnormality that you see commonly in these patients. It's called combined pulmonary fibrosis and emphysema. When you see the pulmonary function test, especially the spirometry of these patients, it looks very normal. The only abnormality that you see is maybe in the DLCO and also in the CT scan pictures. And there are some promoter variant genes are being discovered in relation to patients who have rheumatoid arthritis and who tend to develop problems like interstitial lung disease in the future. So, but this is just at a study level. So this graph, I found it in chest medicine. It is the prevalence of interstitial lung diseases. If you see it, idiopathic interstitial pneumonia is the commonest one, being idiopathic pulmonary fibrosis is the commonest type, around 30%. And then comes sarcoidosis, but the third one is, connective tissue disease associated interstitial lung disease. So this includes like scleroderma, uh, you know, uh, just inflammatory myositis, rheumatoid arthritis, Sjogren's, all the connective tissue diseases. So 15% is caused by CTD-associated interstitial lung disease. And the mortality, if you see it, or the survival.
Special slide about the epidemiology of RA-ILD, or
so that is in the inbuild study. We'll discuss it in the.
Is there any specific number for the how is it common among rheumatoid arthritis patients?
It is, there is no, for example, there is one study that is going on right now. So that study studies only rheumatoid arthritis, but there is no specific study that was done on rheumatoid arthritis, to be honest with you, that I found. The only one I found was the inbuild study. In the inbuild study, they saw some patients with rheumatoid arthritis. They were included in that study.
So it depends in this situation, depends on what data that you're looking at too. But when overall, so it's about 10%, and about 7% is clinically relevant. That means clinically relevance, you see them in the clinic because of visual disease-like symptoms. But when they did some kind of cadaveric studies, it was even present in about 80%. Oh. So that means sometimes it's at the pathological level, it's still there, it's present, but the patient is not symptomatic, like of cough or something like that. They might die of something else. So whenever you see interstitial, so the message is whenever you see interstitial lung disease, whatever the pattern is, and he is going to tell you what common pattern that we see with rheumatoid arthritis. So ILD is not like unheard of with rheumatoid arthritis. At least, so there is that agreement that it's about 10%. And 10% of 1 out of 10 patients with rheumatoid arthritis, it's a big number, but and we still don't know the entire information, but at least it's maybe even much higher than that. Okay. So just keep that in mind. So not to say like this is maybe idiopathic. If you have already well-established diagnosis of rheumatoid arthritis, most likely the interstitial lung disease that you will be dealing with is related to that illness, because that will affect your prognosis and your treatment.
So the survival rate, it's even less than that of patients with breast cancer, especially, connective tissue associated UIP pattern. It is, less than breast cancer, lymphomas, renal cell carcinomas, and colorectal carcinomas. So this tells you the extent of the problem. So this is a study. It is a population study, actually, which was done in Europe, in Denmark. What they found was patients who have rheumatoid arthritis associated interstitial lung disease, they live short as compared to patients who don't have it. So in 10 years' time, most of the rheumatoid arthritis patients with ILD, like 60 to 70%, they already died. But in the same time, it's around 30% of the rheumatoid arthritis patients who died. Usually in early disease, in these patients, you see inflammation with lymphocytic interstitial infiltrates and aggregates of lymphocytes with germinal centers. But long-standing disease, fibrosis predominates, often resulting in different changes like honeycombing, cystic changes, the things that we see in patients with IPF. There are different radiologic abnormalities that we see in these patients, as I have told you. But the commonest one in rheumatoid arthritis is a UIP pattern. Usually, once they develop fibrosis, it will be usual interstitial pneumonia. But the most common type in other connective tissue diseases is non-specific interstitial pneumonia. So NSIP is common in other forms of connective tissue disease, but UIP is common in rheumatoid arthritis. And the UIP usually is associated with better outcome in connective tissue disease as compared to IPF, and the UIP pattern has a worse outcome as compared to NSIP. This is a paper that discusses about like prevalence, incidence, and costs and mortality. In that paper, one important thing that was shown is at 5 years after the first diagnosis, up to 36% of patients. This is just like that of the Danish study that I showed you earlier. So most of the patients, up to 36% of patients, they have already died by 5 years. This paper, it discusses about, different predictors of mortality in rheumatoid arthritis associated interstitial lung disease. And it's around 137 subjects. It's not a very high number of subjects, but around 3/4 of the patients have UIP pattern. The others have NSIP pattern. And those with the UIP pattern, as was expected, they have a shorter survival. And they control actually the age, the sex, the smoking history, and the CT pattern in these patients. The most important determinant for mortality in these patients is the baseline predicted FVC when it is lower, and when there is a greater than 10% decline in predicted FVC. Those determine mortality risk in these patients. And in the same paper, it shows that when it is NSIP is the one in blue and UIP is the one in red. So the survival probabilities, the FVC reduction in these patients is significantly higher in the UIP pattern as compared to the NSIP pattern. And there are significant similarities between the rheumatoid arthritis UIP and the IPF UIP. They have similar demographics. There is similar decline in lung function. There are different mutations that were seen in both diseases, but prognosis-wise, IPF is much worse. For treatment of ARIA-associated interstitial lung disease, we don't have any specific paper which was written. Right now, there is a study, Trail 1 study that is being done that studies the value of pirfenidone in patients with ARIA-associated interstitial lung disease. But people are just using the IPF study to just extrapolate the data into, ARIA-associated interstitial lung disease. That's how they are being treated right now. Pirfenidone, we all know it, and some of our patients are taking it, so it inhibits fibroblast proliferation, and in the mechanism of the disease itself, the transforming growth factor beta is involved, so it basically inhibits transforming growth factor beta. And nintedanib is a TKI, tyrosine kinase inhibitor, and in the ASCEND study, it is pirfenidone. In the Impulsis study, it was nintedanib, which was in 2014, they are approved for use. But these things are being used for the last 5-6 years. So we don't have like a long-term data, even in IPF patients. So we have a short-term data, even in IPF patients. The short-term data shows that all-cause mortality drops when you use these antifibrotic medications, but the long-term mortality benefit is not clear, is not known. This is the Impulsis study that I showed you earlier. So this side, it shows you the FVC reduction or the FVC that goes down in patients who take nintedanib, this one. And this one is for patients who don't take nintedanib. The same thing, Impulses 1 and Impulses 2 are two studies, but they are basically the same result came in both studies. So the other study that I told you, Trail 1, it is the first prospective randomized clinical trial. Only on RAILD, they are trying to get around 270 patients. It is still going on. And it is like multi-center, and they are studying pirfenidone as compared to placebo, specifically in RAILD. Otherwise, we don't have any specific paper in relation to RA interstitial lung disease treatment. This one is, it studies progressive fibrosing interstitial lung diseases. It's the inbuilt study. So it's not only IPF, but connective tissue disease related. ILD was also studied in this paper. The inclusion criteria, usually if there is progress of the disease in the last 2 years in this patient, they are included in the study. Relative decline in FVC of at least 10%, or even if it is less than 10%, if there is worsening respiratory symptoms, worsening HR CT scan findings, they were included in this study. So this is in the supplementary.
What the most recent definition for progressive pulmonary fibrosis disease, right? With the new ATS, so it's 2 out of 3. It's either worsening symptoms and worsening CT scan finding, increased reticulation, blah blah blah. Fracture bronchiectasis, ground glass opacity, and drop in FVC by more than 5% and DLCO by more than 10%. So if you meet 2 out of the 3, then you have progressive, pulmonary fibrosis, regardless of the etiology.
So in this study, if you see, there are so many patients with, fibrotic hypersensitivity pneumonitis, which are around 84, and autoimmune ILDs account for 82. And rheumatoid arthritis patients were studied in this one, but it's just 42 patients. So the study will not have power to say something specifically about rheumatoid arthritis. But people mentioned this study and they put patients on nintedanib. But it is just an extrapolation from the inbuilt trial, even if it is not done specifically for rheumatoid arthritis patients. So the result is this: patients who use with progressive lung disease using nintedanib, whether they have UIP pattern or not, they get, the reduction in the value of FVC is significantly decreased. This indication was started, to be used in 2019. So we don't have any, long-term data, but the short-term data clearly shows all-cause mortality also drops with this nintedanib medication. So people are placed on nintedanib for that reason, due to the inbuilt trial. There are different expert discussions that is being raised.
About the subgroup analysis and the MBEL trial for the, rheumatoid arthritis. As you said, so number of subjects is, on the low side, right?
Yeah.
So when they did the subgroup analysis, it's still showing some benefit, as Yunus said. So, number of patients is not on the high side, but this is always going to be the case for ILD. This is not like a coronary artery disease or some other, other disease, pathology that you're studying. But in those patients, about, 20% on the placebo, on the intervention part with RA-ILD, they, progressed. Despite nintedanib, okay, and that means 80% they had some kind of improvement in their lung function, or at least they didn't continue to lose lung function, as opposed to 40% of RA-ILD patients who were placed on the placebo who had some decline in their PFT. So at least there is a signal that it may help. So even with the subgroup analysis, there was some information that makes us think that this might work for rheumatoid arthritis.
Yeah, I honestly didn't want to mention that because the researchers even didn't mention it because it is significant finding.
I'm not saying this is, great one evidence, but at least, I mean, for the data, doing subgroup analysis has its own, disadvantage but at least it's, if there is a signal that people who were placed on it, they didn't lose lung function, but it's still the sample of, and this is going to be like the case for most of the interstitial lung disease.
That's right. So there are some screening tool options that we need to use for patients with rheumatoid arthritis. Some experts suggest, why do we even screen if we don't have a good medication? But, the studies, the INBUILD studies, the new studies, the trail studies are giving hope to these patients. So I think it's better to do like PFTs yearly, possibly HRCTs as needed, and determination of severity of rheumatoid arthritis. And in the future, I found one paper which discusses about the value of ultrasound in getting early information on rheumatoid arthritis associated interstitial lung disease. So what they do is, if you see the ultrasound, the pleural line is clear, crisp. There is no issue in the first one, in the normal one, on this one. But in the second one, when there is moderate effect, there will be some blurring, some distortion. But in the third one, it's severely involved. There is a significant abnormality that they see. But this is, just a recommendation from that paper. So in the message in interstitial lung disease related to rheumatoid arthritis is we use antifibrotics, but most of the papers are studied in IPF, idiopathic pulmonary fibrosis, not in RA-ILD, and mortality with UIP pattern is higher in RA-ILD, but it is lower than that of IPF. And the effect of drugs for RA, sometimes, patients get steroids, and steroids are said to increase mortality in patients with significant interstitial lung disease, especially in IPF patients. So we have to be very cautious when we use steroids in patients with rheumatoid arthritis with significant interstitial lung disease. And the other thing that we don't have to forget is it is possible that lung transplantation needs to be considered as early as possible in these patients when it's indicated. The other abnormality that we are going to see is organizing pneumonia. We know that there are like plugs of granulation tissue that fills the air spaces, but the walls of the bronchioles and everything is normal in these patients. They usually present just like pneumonia, like multifocal consolidation, usually restrictive defect on PFTs, and they are very responsive to steroids. And it is more common in patients who have problems like inflammatory myopathy, dermatomyositis, or polymyositis, or mixed connective tissue disease, as compared to rheumatoid arthritis. But they could happen in rheumatoid arthritis too. Airway disease in rheumatoid arthritis, usually obstructive on PFTs. They mimic asthma. There are two types, the obliterative bronchiolitis and follicular bronchiolitis. The obliterative type, usually there is granulation tissue which basically replaces the bronchioles with fibrous tissue. And the treatment will be lung transplantation. It has a bad prognosis. But the follicular bronchiolitis, usually responds significantly to steroids, so that can be managed. So when you have mosaic pattern in patients with rheumatoid arthritis, we need to suspect a possibility of airway abnormalities. And pulmonary nodules, single or multiple, could be seen in these patients. Usually, rheumatoid nodules in other places, elsewhere in the body, in the skin, in the bones, or other places are seen first. And when there is cavitation, usually patients present with hemoptysis. And as you can see in this one, you can see that there is a rheumatoid nodule which is very close to the pleura, and that has ruptured and caused pneumothorax in this patient. So that presentation also is a possibility. Pleural disease, I think it is the most common presentation or the most common manifestation of intra pulmonary disease in rheumatoid arthritis. Relatively common. Autopsy studies show that 50% have pleural disease, but only 5% have pleural effusion. And typically the pH is low, glucose is low, and plasma serum glucose ratio is low. It looks like an empyema. That's why we have to make sure that this is not a real empyema. And usually we do pleural fluid rheumatoid factor levels, which are usually high, greater than 1 in 320. So this is another manifestation, usually exudative, looks like complicated type of pleural effusion, is a common presentation of patients with rheumatoid arthritis. The other thing that we need to consider is drug-induced pulmonary disease. We use different medications in rheumatoid arthritis, including methotrexate. Patients can have pneumonitis due to these medications. And most of the time, the presentation of these patients is inflammatory with lymphocytic component, and they respond to steroids, and they respond to, stopping the medication. But sometimes it is very difficult to differentiate whether it is the disease entity, the rheumatoid arthritis, which is causing some pulmonary problem, or the pneumonitis caused by the medications. But if it is, medication-related pneumonitis, stopping the medication and steroids help a lot.
How common is it then?
No, it's so I didn't find a number, to be honest. But what I found is most of it is not that significant. It's not very common.
It's not very common. So methotrexate, as you know, guys, it's one of the most important things that they use to treat especially the articular disease. And you may have mentioned that earlier, that one of the risk factors for having RA-ILD is to have uncontrolled arthritic disease. So your titers are high, you're having active arthritis, that is a risk factor to develop RA-ILD. So with longitudinal studies, when they looked into this, methotrexate decreases the risk of RA-ILD by controlling the disease itself. But the incidence for methotrexate, I think it's kind of overblown. But I think no one has the courage to start people on, especially if you have RA-ILD already. But the disease, the incidence itself, it's in multiple studies, it's less than 1%. But the problem is when it happens, it can be really bad, really bad. And I think you mentioned something about the mortality rate of that. So this is why it's not wrong to treat RA-ILD with methotrexate, but it will be sometimes very hard to say later on how to exonerate the methotrexate if your interstitial lung disease is going to get worse. So this is why people, they don't like to use it as a treatment for rheumatoid arthritis associated ILD. But the incidence for that is very small, and this is why they still use it, very frequently to treat the rheumatoid arthritis as a disease.
Yeah, we already discussed about, the caution that we need to have with steroids in significant pulmonary fibrosis. The same thing applies to in RAILD. Other treatment options. Treatment.
One slide back there. Yunus? Mentioned the Panther study. Is that
Panther, yeah. This was
like to use a steroid like in
so steroids, they were found to be increasing mortality in patients with IPF patients. So usually we have to be cautious when we use it. To be honest, I don't have any specific paper on these things, but I read.
like with the
I actually
there is no randomized control trials to guide the treatment.
yeah.
But this paper that Yunus mentioned here is a big study that they did for IPF because back in the day they thought that this is the future and you to treat IPF with steroids. So they randomized people to placebo where they didn't receive anything, and the other arm as a thiobrin steroid. So they used them together to treat IPF. So they had to stop the study because there is increased mortality rate when it's pure idiopathic, UIB pattern, IBF. That it means. So here we still don't know, especially because it's about 40 to I think 45% of the interstitial lung disease component with the RA is UIB pattern. Okay. So is it going to behave the same way like the idiopathic one? We still don't know, but people they just extrapolate if you have RA-ILD based on your imaging or your biopsy, which you shouldn't do if you have consistent imaging with UIB, along with a solid diagnosis of rheumatoid arthritis, that you're dealing with UIB due to rheumatoid arthritis. So there's still some recommendation that if you're going to extrapolate from that study, it's better to avoid using the steroid in UIB pattern that's associated with rheumatoid arthritis.
So these are just study medications that is being studied for treatment of pulmonary complications. These are my references. Thank you.
Streamline some topics. Sorry, it's just we didn't have enough time to review all of this with Yunus, but I provide Yunus with some of the helpful data that he presented you today. So we discussed how common it actually it is, right? Mm-hmm. So and the interstitial component. So just to sum up, what is the most common interstitial lung disease that can happen with rheumatoid arthritis? UIB. And by the way, this is unique for rheumatoid arthritis. For scleroderma, you said NSIB earlier, right? So it's NSIB for the other. Then NSIB, then organized pneumonia, and then the follicular, if you would consider that as part of your it's the airway disease. But this is the main thing to keep in mind. This is what we see with rheumatoid arthritis. So when do we biopsy these people?
So it's clear.
Was that
Just like an unclear diagnosis
unclear diagnosis of rheumatoid arthritis or
of the reason for the biopsies? Like if you're not sure if it's actually related to the rheumatoid arthritis.
Yeah,
It's rheumatoid and UIPs. It's like
so if I see UIP patient has rheumatoid arthritis, most likely no need for biopsy. But if I see patient has rheumatoid arthritis, but the picture doesn't look like UIP or NSIP, maybe that's the reason to do biopsy.
Maybe if the patient is already on active medication for rheumatoid arthritis, you want to differentiate between like ILD related to medication as an immunosuppression or the ILD.
So it's basically if I try to look at the data about this, and I don't know what you have, Mohammed, but if you have a solid diagnosis of rheumatoid arthritis, okay, and solid diagnosis, that means it's not like well, it could be a seronegative, we have well-established diagnosis of rheumatoid arthritis, okay, because I said interstitial lung disease is common or relatively common with rheumatoid arthritis, okay. There's a wide range between like 5 to 80% and 70% in some cadaveric studies, which is subclinical. So If we have a well-established diagnosis of rheumatoid arthritis and we have interstitial lung disease, I didn't see any, clear data to say that we have to biopsy these people. So whenever the diagnosis is questionable and you have, at least some imaging finding that's not consistent with any pattern, because of course, if you have an SIB, pattern, even if you don't have the rheumatoid arthritis, you're not going most likely to biopsy them if everything is, and especially if there's something associated with it like rheumatoid arthritis. And if you have UIB, sometimes even without any rheumatoid arthritis, then we're talking about the, the classic or the, probable, UIB with the new classification, we don't have even to do the biopsy for that. And if we have organizing pneumonia based on, clinical history, based on, the classic imaging finding, of course, we don't have to. But if you have at least well-established diagnosis of, rheumatoid arthritis and some interstitial changes, even if you can't link it to any specific, I would say like, yeah, it looks UIB, but it's not very classic or probable. It could be, because in this situation, it will be like the risk and benefit. What would I gain from, doing a biopsy to find that in the end, I will have no conclusive diagnosis based on whatever I will get. And even if they will tell me, okay, in imaging, it's not very classic of UIB, or NSIB, but when they did the biopsy, they told me it's NSIB, because the treatment will still be the same. So I think we have to deal with it in a little bit different way from the way that we are dealing with the interstitial lung disease of, unknown cause. And that was one of the, but whenever the diagnosis is solid of rheumatoid arthritis and we have interstitial lung disease, especially if you can, link it to the most common, which is what Yunus said, UIB, NSIB, and, the organizing pneumonia, then I think, and even LIB, it can happen, but those are the main three, then you don't have to biopsy these folks. As far as treatment, steroid, it's not preferred, just for the fear of the Panther trial, especially if you have UIB, fibrotic UIB. The question now is when you have fibrotic and a little bit of ground glass, because we're still extrapolating. These people, they weren't studied. So some people, they use it, some people, they don't. They use different immune suppressive medication, but not steroids. If you have NSIB, of course, if you have the first medication to begin with, if you have, especially non-fibrotic NSIB, and if you have, organizing pneumonia, of course, you will need to use it, okay? But most of the time, even with organizing pneumonia and NSIB, steroid alone is not gonna work, and you might need to add another immunosuppressive medication. And as of now, there is no data to say MMF is better than azathioprine, is better than rituximab. It's across the board. People, they use rituximab, they use, the only thing that you don't have to use and you should not use is number one, cyclophosphamide, unless you're dealing with bad RA-ILD flare-up. And in the flare-up, steroid is justifiable. Steroid and big medicines like, cyclophosphamide, stuff like that, and rituximab, you can use them. Rituximab, there's some promising data that it may work, but it's very small studies. There's no guidelines to make any recommendation. But the lesson to learn, steroid only if you have flare-up, and if you have UIB, it's better to avoid it. Okay, unless you have extensive ground glass, and if you have extensive ground glass, it may not be UIB, it could be an SIB. The other medication, the add-on, it depends. TNF, I don't know if you mentioned, I think when I was outside, the TNF. I mean, you will see people saying, well, it increases the risk of interstitial lung disease, and there's been case reports, but there's no big, case, and in some case series, small case series, not even big case series. So it is something I think that's overblown, and there is no conclusive data to give the anti-TNF. If you give it an RA-ILD, it will make the interstitial lung disease worse. So this is why people, they avoid it, and they avoid the methotrexate for that reason. And I think it's legit, because you have already a problem that's not related to methotrexate, and you're going to use methotrexate when something gets worse, either the natural history of the RA-ILD or the methotrexate. How are you going to tell them apart? This is why they avoid it. But as medicine, it controls the disease, and hence it decreases your risk for, interstitial lung disease, RA-ILD. What else that we, the problem is very vague. Steroid plus something else, but there is no data to, guide where to go. I think with this, I mean, people, they use it not because of rheumatoid arthritis, then nintedanib, but if you meet the criteria for PPF, progressive pulmonary fibrosis, then you just, because people now, they argue that that's the common pathway for most of the, regardless of the interstitial lung disease and what caused it, if they progress in their natural history and they get to that point, it doesn't matter whether it's, autoimmune, whether that's, chemical exposures, whatever genetic, idiopathic, they will continue to progress, and offering them, antifibrotic treatment is going to be, helpful to kind of, slow down the progression of disease. I think we're still doing if you're gonna give it, you have to follow the, regimen and, dose and everything like what we do with IBF, and to check their, I think, PLFT very frequently in the beginning, and then, you can do it, infrequent later on, just to follow the IBF profile. But there is no data for the rheumatoid arthritis, as what Yunus said, in and of itself. And I think he just today taught you about, and good job for this very high, highly, difficult topic. But you have to understand that it's not just only this one. So he, I think, gave you a hint that it can affect your airway, your vocal cord, your trachea, anything. Your can cause pleural effusion, pleurisy, and everything.
Thank you.
Thank you.
Thank you.
Good job.